Good evening, my respected seniors and my dear friends. We welcome you all in this fifth session of ISCCM Journal Club. I am Dr. Tanmay Ghatak from SGPJIMS Lucknow. Along with me today is Dr. Raghav Gupta from AIMS Delhi as a club coordinator for this ISCCM Journal Club. Our Journal Club is conceptualized by our President-elect, Dr. Ranbir Singh Tyagi sir, and it has a tagline that goes like that, simplifying evidence-based medicine to bedside medicine, so that we can practice and prescribe evidence-based medicine from bench to bedside practices and homogenize the critical care practices all over the country. Our ISCCM Journal Club objectives are not only to promote evidence-based medicine at a wider level, as said earlier, but also to critically appraise the recent practice-changing research articles and to encourage and enhance the learning by imbibing those breakthroughs for our own professional development. With this overview, I want to introduce our respected guides, Dr. Manish Bharti sir from Jatharth Hospital, Delhi, and Dr. Neeraj Kumar from AIMS Patna. Both of them have done Herculean task by initiating this ISCCM Journal Club. Welcome, both of you, sir.
Thank you. Thank you.
And our expert for this journey today is none other than the doyen of research methodology in our country, Professor Rakesh Garg sir from AIMS Delhi. It gives me immense pleasure to have you, sir, in this ISCCM General Club meeting, and I welcome you, sir. Our respected President-elect, sir, Ranbir Tyagi sir, already showered his word of blessing through phone that you go ahead, and thank you, sir, for giving us the opportunity. Now, today we have two wonderful studies for presentation as well as dissection and critical appraisal. And both of them are from a top-notch journal. One is from NEJM and another from Annals of Intensive Care. And both are having 800 plus patient base. So without much delay, let's start our first study, that is early Tirofiban Infusion after intravenous thrombolysis for stroke. That is published in NEJM this year, July, and it will be presented by Dr. Amos Tamang. He is IDCCM student in Neutia Gatewell Multispecialty Hospital, Siliguri, and to be mentored by my dear friend, my MBBS batchmate, and AS intensivist, and first ISCCM Secretary Siliguri branch, Dr. Pradipta Bhattacharya. I welcome you both, and as a warning and caution, it's a time-bound exercise. You all know. Please finish your presentation by 16 minutes so that we can discuss till 7:30. I think so for the first topic. Please, over to you, Dr. Amos.
So just a second, Dr. Tanmoy, you can keep the timer on, and once we have crossed the 18 minutes, you can let us know. So we will close the first case presentation.
Yeah, thank you.
Thank you. Thank you. Please go ahead, Dr. Amos and Dr. Pradipta. Yes.
6+7.
Good evening, respected teachers. Today I'll be presenting a journal on early Tirofiban infusion after intravenous thrombolysis in ischemic stroke patient. It was authored by Dr. C. Tao et al. And my mentor is Dr. Pradipta Bhattacharya. According to the current guidelines, after ischemic stroke, in this journal, tirofiban is used, which is a group 2B3A receptor after thrombolysis. So basically, it is used as a bridging therapy between the after thrombolysis and before starting the antiplatelet therapy. So this is a study which was published in NEJM in the year 2025, July 4th. And it was conducted. It was conducted in China in 38 centers, And here, these are the few studies to show that the tirofiban was used, and it was used as a bridging therapy in bridging therapy after thrombolysis and before the start of antiplatelet therapy. The aim of the study is to assess the efficacy, safety, and functional outcome in the patient with ischemic stroke. It was a double-blind, randomized, placebo-controlled study which was conducted in 38 centers in China after ethical clearance, and it was funded by the university. The patient selection in this trial, the adult patient above the age of 18 years with non-cardiomyopathic stroke, and the patient who received IVT intravenous thrombolysis within 4.5 hours of stroke onset with NHS score of 4 to 25 was taken. The patient excluded in this trial were the pre-stroke patient who had a disability in a modified Rankin scale of more than 1 and history of atrial fibrillation, and the patient who underwent planned mechanical thrombectomy, and a patient who had evidence of intracranial hemorrhage in neuroimaging. Altogether, 1,699 patients were assessed in 38 centers. It was central randomization was done and was stratified according to the trial center. The randomization was done after intravenous thrombolysis. All the trial personnel and patients were blinded in this study. Intervention. Post thrombolysis, tirofiban 0.4 microgram per kg of body weight was given over 30 minutes, followed by 0.1 microgram per kg for the next 24 hours. Placebo was also given as same as tirofiban. The primary outcome the author wanted to see was the excellent functional status at 90 days, which was seen in the which was seen by a modified Rankin scale from 0 or 1. Secondary outcomes that were seen were functional independence, independent ambulation, neurological function in terms of NHS score, quality of life, and independent function in terms of Barthel index. The primary safety outcomes were symptomatic intracranial hemorrhage as per SITMOS criteria and date within 90 days. Secondary safety outcomes were asymptomatic intracranial hemorrhage, systemic bleeding within 90 days, and adverse event within 90 days. Coming to the characteristics of the patient at the baseline, the median age of the patient were 69 in both the groups, in tirofiban and placebo group, and median NHS score was same in both the group, that is 6, and median NCCT aspect score was 10. In this study, the cause of stroke was mostly a large artery atherosclerosis, which was almost same in both the placebo and tirofiban group. The median duration of completion of thrombolysis after randomization was same in both the tirofiban and placebo group, that was around 30 minutes. And post tirofiban, mono antiplatelet therapy and dual antiplatelet therapy was used in both the groups. Sample size. The total enrollment of 788 patients, each 394 in each group, with power of 80%, with difference of 10 percentage point in primary outcome with significance level of 0.05 was taken, and 5% dropout rate with final sample size of 832 patients were taken. statistical analysis. The final sample size was 832, which completed 9 days of follow-up, in which one patient didn't turn up. The primary and efficacy and safety was seen through modified intention to treat principle. Distribution of score on MRS was analyzed according to the ordinal logistic regression, and multiple variable analysis was used as per age per stroke on MRS, time of stroke onset, administration of tirofiban and placebo, and stroke severity. Now coming to the primary and secondary outcomes, the modified Rankin scale was 0 to 1 in the patient with 0 to 1 in tirofiban group it was 65.9%, and in placebo group it was 54.9%, which was significant. And in 0 to 20 days, at 90 days, in tirofiban group it was 80.4%, and in placebo group it was 72.7%. The safety outcome in terms of death, it was same in both the tirofiban and placebo group, but in terms of intracranial hemorrhage within 36 hours, it was more in tirofiban group, which was 7 versus 0, nil in placebo. In subgroup analysis, the NHS score was more than 8 in patient in tirofiban group, though the modified Rankin score it was 0 or 1. Now coming to the discussion, tirofiban actually showed a disability-free and functional independent outcome, which was 65.9% in tirofiban group and 54.9% in placebo group. But there was increased risk of symptomatic intracranial hemorrhage of 1.7 in tirofiban group. There were other studies also conducted, which was published in Journal of Neurology in the year 2024. It was a single-center randomized trial in which tirofiban was used, but in which it showed improvement in a modified Rankin score of 76.1% versus 63.6% with statistically significant p-value of 0.04. But there was an increased risk of intracranial hemorrhage in tirofiban group, which was 4.47. The other was the MOST trial, in which another group 2B3A receptor was used, eptifibatide. It was seen like there was the incidence of ICH in eptifibatide and placebo. It was almost same, and there was no any significant difference in the modified Rankin scale. It was 6.3 and other was 6.8. In ARIS trial, in which argatroban was used, although in placebo, in the control group and argatroban group, the functional status was same, but it was not statistically significant. The other trial was ARTIST trial, in which aspirin was used, but it was terminated early because of increased ICH, symptomatic ICH. Critical appraisal. This trial was a robust trial, and it was a randomized controlled trial. So internal validity was there in this trial, and that the purpose and objective of this trial was also met. That was the excellent functional outcome in with a tirofiban group compared to placebo. In methodology, the trial was powered 80%, So this trial was powered, and the baseline characteristics in tirofiban and placebo group were same. The possible bias maybe it was there because out of 1699 patients, only half of the patient participated in this trial. So there could be possibly a selection bias. The primary outcome in both the groups was analyzed. The primary outcome, which was excellent functional status, that was also defined properly, and in secondary outcome also it was defined in terms of modified rank scale, 0 or what, 0 or 2, and the confidence interval was also reported, which was 95%, and dropout data was also taken in here. It was one patient among all the patients. The limitation of the trial. Though this trial was conducted in China, and it was only conducted on the patient who had a cardioembolic stroke, and the patient enrolled in this trial was only a patient with a mild stroke. So the generalizability of this trial can't be said properly. And the limited time window, the spontaneous intracranial hemorrhage was seen within 36 hours of thrombolysis. Although the chances of hemorrhage within this period is high, but after 36 hours, the assessment of ICH was not assessed beyond this time. The lack of systemic vascular imaging before the start of tirofiban or after the start of tirofiban, it was not done. So the full assessment of baseline vessel occlusion and how it was recanalized with the drug cannot be commented. Coming to the summary, tirofiban has significantly improved the functional outcome at 90 days, but with an increased bleeding risks. But overall safety remained within the expected range. Tirofiban post-thrombolysis, so promising results, but more trials need to be done outside China for external validation. So basically, this trial was conducted in only China, where the risk of cardioembolic stroke is not so common there. With this, I will come to an end of my presentation. Thank you.
Thank you, Dr. Amos, for this concise talk. I think right in time. And I'll request respected Professor Rakesh sir to critically appraise or say some words for this. I think sir has joined. Rakesh sir?
Yes, he
yes,
is there.
Sir is there.
No problem. In the meantime, we can take the
By the
question.
time, Manish, our guide, please, Dr. Manish sir or Neeraj, please chip in and say something about this. If you have any question on that, we can discuss.
So first of all, thank you, Dr. Pradipta. He's the mentor for this session. And of course, Amosh Tamang for taking this exercise. Really loved, especially the precision in terms of the delivery, because we were able to finish on time. Tanmoy, my only question and my only submission is this: how will you translate this study into the bedside evidence-based practice? So let's say one thing which I fail to understand, they have chosen the patients with a mild stroke. So the mild stroke patients, especially who are having a non-disabling the stroke per se, they anyhow don't need the thrombolysis. So very difficult to say that the kind of a patient which they have chosen is actually very mild variety. So that is something which needs an introspection, whether in our setup, the mild stroke patient, especially with the non-disabling stroke, should it be thrombolized or not? That is one. Secondly, I would like to know from maybe Dr. Pradipta, because he must have gone into the detail. There's no doubt that the patient who have received the thrombolysis, they should be on antiplatelet therapy thereafter. So which we have been doing it as the standard of care. Now, in this kind of a case, in this study, specifically, they have seen the patients who have received Tirofiban infusion, they have an increase in the incidence of ICH, almost 1.7%. So do you can identify for our bedside practice that what subset of patient should be chosen for the tirofiban therapy so that we can minimize the risk of ICH in case if we're using tirofiban after the thrombolysis for the patients? So maybe Dr. Pradipta or Dr. Ramesh.
Hi and good evening, all teachers. So you are resonating one of my concerns, like one, the population here has been taken as a patients of mild to moderate stroke, I would say, and that there is an issue regarding we are not giving any therapy within the 24 hours after a thrombolysis. Okay, we are starting antiplatelets after 24 hours. So I think they are trying to fill this gap with giving something in this window period of 24 hours. So what's the problem? Problem lies that after thrombolysis, there could be a possibility of reocclusion of the macrovascular reocclusion or microvascular thrombi, which might affect the long-term functional outcomes. They want excellent functional outcomes. They already know that baseline of 50% will already be there with the thrombolysis and the controls. So they wanted to do this study with the idea of improving that percentage of patients who will have excellent functional outcomes with no or minimal disability at the 90-day period. Okay, so this is the idea of why the study has been done. Overall, which the previous small trials had been done, the proof of concept study and then one single center study, they had shown that the tirofiban is not increasing ICH to a great extent. And this study has also replicated that it has not had very high percentage of ICH, symptomatic ICH. It's at 1.7%. Now, in the real world scenario, will that be acceptable or not? That is a question A. Outside of China, whether what are the percentage of patients who are with this kind of population? I was giving a search about what is the target population here. Like in our country, if we say that patient coming in the window is already very small. Within the window, not many people outside maybe the metro cities are around 5 to 10% if I'm giving them a good percentage. Out of that, thrombectomy is not done in many centers. So the percentage is not very high in Indian population that we can choose for this kind of therapy, that the tirofiban therapy. Aspirin has been tried, the other antiplatelets, if they can be given earlier than 24 hours, which is still not a norm, but they have failed because they have shown increased increased ICH. So we are still sticking to the 24-hour gap between the end of thrombolysis and starting of antiplatelets. So in Indian population, if we are coming to only Indian population versus the world population, we have a slight difference here. In the world population, we'll have a 22% around cardioembolic stroke, which they have taken out. So remaining 78, in good centers, they would have this.
Why they have taken cardioembolic stroke? Why they've excluded the cardioembolic?
Yeah, the cardioembolic stroke has been taken out because of the nature of the clot which forms in the cardioembolic stroke. It's a fibrin-rich clot. And the atherosclerotic strokes would be more of a platelet-rich clot. So there is a difference between the type of clot. So they have estimated that this would work better in the this platelet-rich clot. And the beauty of this GP2B3A antagonists in this case, they have been used extensively in the acute MI setting. But here, what they are trying to do is with the aspirin and clopidogrel, or aspirin mainly, we are completely inhibiting the platelet aggregation for maybe a long time because their duration of action is quite long, 7 days. Okay. And
sorry, Pradipta, I'm just interrupting you. I think my question is lost. I just want to understand. Let's say I'm a trainee and I have to choose tirofiban therapy for my patient. Can you simplify the check-in patients where it will be safe to use it? For example, to demonstrate the maximum benefit for this therapy in case if we have to really use it. In other words, what subset of patient would you like to choose? 1, 2, 3, 4, so that the trainee can assimilate this piece of information. Thank you.
So according to this is a single country trial, okay? So to replicate it directly to our population, it's still not there. It's still not there.
Great.
Second trial, Advent trial is ongoing, which is a slightly bigger trial, and they are doing it after tenecteplase. So it is also a Chinese trial. So outside of Chinese population, we have to see what is the nature of stroke, and these things have to be considered before actually using it in real world scenario, especially in Indian population. So we are still not there.
So we don't have any specific subtype where you feel tirofiban therapy will give us an advantage.
The subtype which has been mentioned here, which has been mentioned here is the patients who are going to have a intravenous thrombolysis within 4.5 hours and not expected to have this endovascular therapy. Okay. So, and obviously they will not be cardioembolic stroke patients. Non-cardioembolic stroke patients undergoing IVT, but not being eligible for EVT. Okay. These are the subset of patients which actually have been chosen for this trial. Okay. For this intervention.
Thank you, Pradipta.
Manish, can I add one thing?
Yeah, please.
They have not cleared the why thrombectomy is not done. I think large facial stroke, we are more familiar with the thrombectomy therapy. You know? Secondly, continue with your question. The non-AF population who are having stroke, they have chosen that this patient may be helpful with tirofiban therapy. But one thing in Indian population, it is difficult to give a 24 hours infusion like this scenario. More they are more preferred like tablet and everything. So for tirofiban infusion, I think we take it a pinch of salt. And what about the other therapies like maybe bleeding may be related to altiplase or tenecteplase what they have used, thrombolysis, that may cause bleeding. That bleeding is not directly related to tirofiban as well.
Right. So, thank you, Tanmay. Thank you.
I think 7:30, the comment would be that the comment would be that.
Can I make some quick comments?
Yeah, Neeraj, take a minute.
Yeah, I think thank you, Dr. Tanmay and Dr. Raghav and I think Dr. Amos, very good attempt for this nice presentation. Just in the methodology, I just want to add few things which I read just right now while going to the study. I think 2 or 3 important things that has been already discussed, that it is a single center study. So it is not generalized to more diverse population. So first limitation of
sorry to interrupt, it's not a single center study.
Yeah, it's in China. It's in China. It's related to China.
38 centers in China.
So it is not generalized to some diverse population like the patient will having different stroke mechanism, right? So this is, I think, one of the limitation we can say, and I think Dr. Tanmay already quoted one important thing is about that exclusion of that thrombectomic patients. Now again, it limits the applicability of this result because there are various large vessel disease. There may be some large vessel occlusion for which mechanical thrombectomy may require, but they have left out those groups of patients. Now coming to the few points about the patient selections. While I was reading, they have kept that only patient randomized within 55 minutes post thrombolysis they have included there in their eligibility criteria. Again, it's a very tight. It doesn't reflect the real world real world scenario, which is difficult to. And the third point already cardioembolic strokes. Dr. Manish already discussed that why they have omitted these cardioembolic strokes. They have included, I think it's very well answered by Dr. Pradipta as well. Now, second point was the baseline NIHSS value that they have taken from 4 to 25. So what does it mean? It means they excluded very mild and they excluded very severe strokes. Now, again, it is posing some important impact over the disabilities, because if the patient will have a mild or very severe strokes, the disability will vary. Now, the next point is in the interventions, the timing of that tirofiban doses. I think again, Dr. Tanmay has very well discussed about it, that they have fixed that duration of 24 hours, but that's why again it is very personalized. And then they may be saying about under treatment or some over treatment like that. And the last point that I want to discuss here is they have taken a MRS score from 90 days. Now, when you read about this MRS score of 90, that why they have used that modified ranking score for 90 days only, why they have selected that 90 days values. So when for that, I was reading this part, I think it was very interesting to for you all to know that if you use that MRS, they use because at these 3 months, most of the recovery from ischemic stroke has been plateaued. So this 3 months, the plateau phase for ischemic strokes will be there. That's why the disability status will be stable. So this is the reason of taking MRS as 90 days. So these are few of the takes from my side. Thank you.
Excellent.
When you're talking about 90 days, I think bleeding has not been taken care of till 90 days. That is also a problem.
It's the gold standard. Yeah, it's a gold standard. Means if they are using MRS for stroke trials, they use that 90 days models. I thought that I should add it here only because they are because most of these ischemic stroke get plateaued at this point of time. That's why they are using this 90 days cutoff.
Excellent, Neeraj. I think Tanmay, you would like to go for the second case?
Yeah.
Okay, please.
So, despite a good study, it has several limitations, like conducted in China, or exclusion of the cardioembolic stroke and thrombectomy eligible patient is not cleared. So we can take it in India with a pinch of salt for the study. So with this,
second case.
Going to second case. Dr. Raghav, kindly introduce the second team and please initiate.
Sure. So good evening, one and all. Thank you to our guides, Dr. Neeraj sir and Dr. Manish sir, for wonderful discussion for the first paper. And thank you the team from Siliguri for a wonderful insight and wonderful article. Now we'll have a second team coming from Agra. And we have the mentor for this. Can I ask them to please share the screen first? Dr. Atiharsh and Dr. Gaurav. So they will be presenting a very wonderful article titled Angiotensin II, Conventional Vasopressor Therapy and Mortality in Shock, a large multicentric propensity score weighted analysis. So over to you, Team Agra. I would request you to kindly share your screen.
So we are going from Siliguri to Agra now.
Yeah.
Dr. Gaurav, is there?
So meanwhile, by the time Dr. Gaurav is sharing the screen, Dr. Atiharsh sir, can you just briefly tell something about the next study which we'll be presenting?
Hi, first of all, good evening, everybody, and thank you, Tanmay, and the entire ICCM team to give us this opportunity to discuss. So I think as we all as intensivists, we have this, I think, a big dilemma when sometimes the patient comes with a septic shock and we are just, we are just struggling with the 3-hour bundle where we want to give fluids, we start vasopressors, we want to attain a MAP of like at least 65 that we all know. But sometimes we like struggle where we are giving fluids like 30 mils per kg and we are giving like vasopressors. But sometimes in some cases where we all know in sepsis, patients are very catecholamine like depleted just because the progress of the disease is so fast. We kind of struggle to get to that figure of 65, that magic figure of 65. And that's where I think 3 of the, modalities that we normally choose to get to that magic figure is we go for catecholamine mediated, vasopressors. We go for vasopressin 2. And then there's one more, this new modality which has come up, that is the renin angiotensin aldosterone system. So that's where the role of angiotensin II. I think it's approved in US. I think it's coming in Asia. It's not very much in use in Europe, but I think it's the third modality. It's coming in very rapidly, and I think the primary aim is it's a non-catecholamine. Its action is non-catecholamine mediated, and ultimately it gives us an option where we are struggling to reach to that a map of 65. So we have got that third kind of mediator where we can use angiotensin II infusions and achieve our 3-hour bundle target. So this is a good study which is published in Annals of Intensive Care, which I think Dr. Gaurav will present, and maybe it will be useful for all.
Thank you, sir, for a brief introduction regarding the article which we'll be presenting. May I request Dr. Gaurav? Adhish, sir, in that case, can you please just cover up?
Sure, because we have to finish on time.
Yeah.
Yes.
Let us please chip in.
Good evening. Good evening, sir. I'm Dr. Gaurav.
Okay.
I'm presenting
camera, Gaurav, camera on kar lo yaar, please.
Yes, sir.
You're audible, but not visible.
Yes, sir.
Nahi ho raha, not issue. Start kar lo.
Yes, sir. There is some issue there. I'm presenting the case for the angiotensin II conventional vasopressor therapy and the mortality in shock. My mentor is Dr. Atiharsh Mohan Agrawal from SM Medical College, Agra. This is the original article. Angiotensin II is often used with the adrenergic agent as a vasopressor in shock. Study evaluate whether angiotensin II improves outcome when added to conventional therapy. The retrospective analysis of this is the retrospective analysis of 811 patients across the 4 centers. And the finding was the angiotensin II associated with lower 30-day mortality at a specific norepinephrine equivalent doses. Shock is the life-threatening state with inadequate tissue perfusion and organ dysfunction. A conventional therapy is catecholamine, norepinephrine equivalents, and vasopressin. Angiotensin II is an alternative vasopressor, potent vasoconstrictor. Evidence on its optimal role remains limited. Multimodal vasopressor therapy may reduce the high-dose catecholamine side effects. This research raised the questions about does it angiotensin II improves 30-day mortality in shock patients, and is the effect depends upon the baseline noradrenaline equivalent doses. This method of the study is the design is the retrospective studies conducted between the March 2028 to 22, and population was 811 ICU patients, of which 275 received angiotensin in combination with noradrenaline equivalent, and 536 was conventional therapy only. Data collected was demographic, SOFA score, lactate, comorbidities, norepinephrine doses, propensity score, and inverse propensity treatment weighted used for covariate balance. Primary outcome was 30 days mortality. This is the statistically, this is logistic regression for univariate and multivariate analysis. Propensity scoring plus inverse probability of treatment weighting. Stratification by noradrenaline dose in increment of 0.1 microgram per kg per minute. Sensitivity analysis for high output shock patients. Total mortality was 56.4%, and angiotensin II associated with lower mortality. Odds ratio is 0.65 and p value is 0.025. And after inverse treatment weighted effect, preserved odds ratio is 0.74 and p value is 0.040. So far, score, lactate, age, and norepinephrine dose also independently linked to mortality. The lower mortality with angiotensin II at norepinephrine dose more than 0.4 and more than 0.5 microgram per kg per minute. No mortality benefit at noradrenaline more than 0.6 microgram per kg per minute. The trend towards the lower mortality at norepinephrine equivalent less than 0.03 microgram per kg per minute, but sample is small. This suggests benefits within norepinephrine dose window, 0.4 to 0.6 microgram per kg per minute. Angiotensin may reduce the mortality in shock at moderate norepinephrine doses. Finding align with prior studies, Ethos trial, and use of inverse probability treatment weightage improve Robston compared to earlier analysis. Results are hypothesis generating prospective trial needed. The limitations of the study was the retrospective design. Causality cannot be proven. Potential unmeasured confounders, that is renal functional details. Small sample at low norepinephrine equivalent doses less than 0.3 microgram per kg per minute, and limited hemodynamic data available for many patients. Conclusion of the study was the angiotensin II with conventional therapy linked to lower mortality in shock. Effect strongest at norepinephrine 0.4 to 0.6 microgram per kg per minute. No benefit at norepinephrine more than 0.6 microgram per kg per minute. Further prospective trials required to define the role in septic shock. That's about the study.
Thank you, Dr. Gaurav. So based upon your study, I would request Dr. I would request Dr. Neeraj sir to kindly share your insight onto the study and if you have any questions.
I think it is a very good study, and I really congratulate Dr. Athias Agrawal sir for mentoring this session as well. I think if you'll talk about some study caveats, that what was I was very quickly seeing this article because it is really very well written article. So first important thing is the retrospective nature of this study. I think we all agrees to it because there should be some because this study may be prone to some missing data or as well as some misclassification. The first important caveats that I will talk, and the second is that I think Athias sir will then further put some more insights into it. Like they have provided the discretion in angiotensin II initiation. Again, it's a very strong risk for confounding of indication of using this because there may be some sicker groups of patients that may preferably going to receive this angiotensin II, or the you can say that the selection of the patient, I think again it's a challenging one, and then second the single healthcare system. So they have there again the entire generalization of this result will be different because they have used a single healthcare system. So again, this is one of the caveat. When you read about this study, they have started this study in 2000, means retrospective 2018 to 2022. So at that time, the COVID was there. So again, it is ICU case mix study. We can say that it may be variable, it may be atypical, or the study period is overlapping with COVID period. So they have not mentioned anything about it. So the ICU case mix or some phenotypes of shock may be one of the factors. I was reading one more part. I think again, it's a very interesting for all our enthusiastic listeners, those who are listening, is vasopressor equivalence formula. When you read about this vasopressor equivalence formula, they have written that norepinephrine plus epinephrine plus 2.5 multiplied by vasopressin. Now, this formula, when you will read further, it is very widely cited, but not universally accepted. So this is again one of the, it is showing again a very linear correlation or not very equipotent because the formula, the equivalence formula, they have based their study in this. And last point that I want to make is to clarify, they have not mentioned about that high output shock definition. So how they have done that, how high output shock definition, because this relies on many hemodynamic parameters like your cardiac index, like your central venous pressure, like your ScVO2 as well, and they are not routinely measured in this study. So again, it is most vulnerable to misclassification bias, you can say. So these are 4 important points from my side for this study on the methodology only. Thank you.
Thank you, Neeraj. So Manish, sir.
Thank you, Dr. Raghav, and of course, thank you, Atish. This paper has been close to my heart, so I requested Dr. Tanmoy and Dr. Raghav to take this paper because I do a lot of work on sepsis. So just for the mentees, because otherwise we have already done and maybe you can disagree, Atish and anybody. What we have seen that nowadays the patients are dying because of a catecholamine excess, not because of a catecholamine depletion. And it's a catecholamine-induced organ dysfunction, which is becoming a big concern in the modern medicine. And that's why the therapies to target the anti-adrenergic mechanisms in the form of a vasopressin or the use of angiotensin or even the use of methylene blue, they have been taken into the shape. So I feel if you really want to use it to a success, it should be chosen early. I think 2 sessions back, Neeraj, we had a study onto the vasopressin as well. The Oasis study.
I remember that.
If you could. Yes. So even in that paper, what we learned, Atish, Tanmoy, Raghav, and Pradipta and Neeraj, that if you have to use vasopressin, it has to be chosen as early as less than 4 hours of the onset of the septic shock, not to the cases when the patient becomes terminal. And then you say this therapy is not working. So please do not use in advanced organ failure. It's not going to work. So that is one. Second is, now this is counterintuitive. Generally, the people, they use alternative therapies like vasopressin or even angiotensin when the patient is becoming refractory. So the endorsement which I can see in this paper, as well as from the Oasis study and the past paper, is that when the patient is having a less severe septic shock. For example, here they have said if the dose requirement is between 0.4 to 0.6 micrograms per kg per minute. Even for the vasopressin, they have said if the dose of norepinephrine is less than 15 micrograms per minute. There it works wonders. Third, the catecholamines, the use of vasopressin and angiotensin is not just to improve the blood pressure. So if you see the disease physiology of a septic shock, it also causes relative vasopressin deficiency. And that's why when you choose vasopressin, you're also supplementing vasopressin as a hormone, which is also important. Secondly, there is also documented angiotensin deficiency. So the role is much beyond just to use as a vasopressin. So that is what, I feel should be the choice of a discussion in the next, let's say in the 5 years or so. So I personally feel, one has to tailor-made, of course, the vasopressor therapy. And the successful vasopressor therapy should be an armamentarium where all this vasoactive therapies plays an important role. And last, which Dr. Neeraj has said, as far as the high output, I think the intention is that if you're using angiotensin or vasopressin, it has to be a vasoplegic shock, which means by definition, it has to be a septic shock. So either you demonstrate through the non-invasive cardiac output means, or you use the invasive data, but for sure, the role is very limited when it comes to the cardiogenic shock and of course, hypovolemic shock. There it should not be chosen. So that is all my submission. Thank you for giving me 3 minutes. Yeah,
thank you so much, sir, for your wonderful inputs and guidance. Rakesh sir is also there, and sir is probably, I would request sir to share his expert views on this.
So I think boss has already mentioned, so I was just saying the type of study. So just when we do a critical appraisal of the paper or read a paper to change our clinical practice, I just want to highlight from the statistical point of view. Now, this is not a randomized controlled trial. This is an observational study where they have collected data and they have done the propensity matching, weighted matching actually. So this is when we present these type of studies, we need to understand its limitation. When we publish the observational studies and compare the groups, there has huge amount of bias confounders and various covariates which will not match between the groups. So here they have used various parameters, and we know that managing the drugs, norepinephrine or angiotensin II here, is not only for maintaining blood pressures, but there are many other factors which would influence. And what they have done is propensity weight matching. So when you read the studies, try to understand the factors. Now, when it is a propensity matching, it is usually the characteristics which are matched, and then they try to compare the two groups. So when you critically appraise the papers, you need to understand whether there are any unknown factors which could have influenced the outcome. Where in this study, it is 30-day mortality. So when we try to analyze this paper for a clinical translational value, we need to understand that during the matching process between the groups, whatever the variates they have used are the only variables that could affect the outcome. If yes, then it's fine, you can take the results. If no, then it becomes a huge limitation, as in this study, because there may be many factors which they have not disclosed into this study. The good thing that they have done is they have weighted the propensity matching. This is an additional higher level of matching process where every covariate is given some weight, and this weight is based on regression. And then they do the matching based on those weights, and then try to compare, which in this study they have compared when they have used different dosages of norepinephrine and try to compare it with the angiotensin II and try to look for the 30-day mortality. So this is increasing the robustness of these type of observational studies, though a non-randomized, but these propensity matching, weighted matching will give you a better clue. But always remember, when we do an RCT, we matches known and unknown factors. But when we do a propensity matching, we are only matching the known factors. And when we say about septic patients, we understand that the physiology is very different, and we do not even today understand the total physiology. So be cautious when we interpret this data, even for these, and RCT remains one of the best. So this is what I say when you read further studies, try to understand the statistics aspects also, so that you understand that statistics and the study design itself can be the limitation factor when you see your patients, when you see a patient population which has a different demography and probably different pathogenetic phenomena. And that's why they may not behave the same thing. So a little understanding of the statistical aspect. Back to you.
Thank you so much.
Sure. I think Rakesh sir has talked very well, because that propensity score modeling is itself, it's a very interesting subject, what Rakesh sir has already told. And just for all our viewers that who are watching, sir, what sir has told, that they have in this propensity, you measured the covariates, right? You measured the covariates. So there should be always a unmeasured confounder. So unmeasured confounders in these groups of patients may be the clinical judgment. While reading the study, you can understand that there may be clinical judgment, one of the points, but maybe the fluid responsiveness and maybe the distributive shock physiology. So these all three may be the maybe unmeasured confounder. That's why this propensity score modeling, that what sir is talking about, that they do with stabilization of that weights. So this is, I think it's a bit complex, but Rakesh sir has told it in a very simple way. But just I thought that I should add these unmeasured co-founders. Thank you.
Thank you so much, Rakesh sir and Neeraj sir, for sharing your insights on this little complicated, but making it much easier for all of us. So, Tanmay sir, over to you.
Can I call it a day, sir? Rakesh sir and other guides, or Atiyars will add answer something. Atiyars?
Yeah, I think what Dr. Manish, Dr. Neeraj, and Dr. Rakesh sir I think added was so good for the viewers and all of us. I think my experience personally with the angiotensin II is, I think, zero. But I did read about this paper, and I think angiotensin II as of now doesn't figure in any of the surviving sepsis campaign guidelines. But I think it's a interesting drug. It's coming in, and as I think sepsis is behaving in a very awkward way. I mean, patients do present in a very haphazard kind of a presentation and probably just a very short history. I think angiotensin II will find itself in the shelf in most of the ICUs, and it's coming in. But as Dr. Rakesh sir and Dr. Neeraj and everybody just pitched in, I think we need to understand more about it, where to use it, what are the specific implications where it works the best. So it was very, very informative, and I think with experience we'll learn to use it in the right way and in the right patients. And hopefully it will improve our mortality outcomes or survival outcomes.
Thank you, Atyars. I was
Dr. Tanmay, I think Dr. Pradipta is also there. If he wants to add something. He was listening to that entire lecture. Yes. If he wants to comment something. Dr. Pradipta, do you want to add something?
Second one?
Yeah, for second one, right? Definitely.
Yeah, so angiotensin II, I don't have much experience, to be fair. And obviously, we will be waiting for prospective trials before commenting on the usefulness. Many drugs will be tried, as has been tried in sepsis and septic shock. Some have fared well, some not much. So we'll have to wait for a proper trial to come, and then we can actually take it into consideration. But the concept is good, multimodal. I always like multimodal, whether it be analgesia, whether it be this, not that all the receptors should not be overloaded. The catecholamine receptors, that's the concept behind the vasopressin also being a hormone, as Dr. Manish has already mentioned. So those things are there, but vasopressin without being the first drug has not worked so much well as we have seen earlier in the studies. So after the catecholamines, these are add-on. These would be the add-on drugs, as we can see, and only in vasoplegic ones. Yes.
So thank you, Udit sir. Manish sir, will you add something?
No, I think we are just waiting for an era, Pradipta, that when in septic shock, people will measure the catecholamines level. If they're already in excess, people will stop using catecholamines. I'm just waiting for that time. Unfortunately, by the time the guidelines they reach with anything, we have already experienced it multiple times. Even for vasopressin, when I was a trainee and I was very keen to use it, still there was not there in the guidelines. So, but we can all sense it. It's a common physiological sense. So let's be open to the concept, as we have already agreed, and let's agree to disagree that not everybody is going to use it at the same time. Thank you, everyone.
So, Manish, what are you suggesting? One head-to-head trial with vasopressin versus angiotensin II.
If you ask
me, it will be a good idea.
Yeah, there has to be. I won't say head-on trial because it's very difficult, particularly in sepsis, because of the different subsets, the kind of the prototypes, it's very different and very difficult. But for sure, sepsis has been always enigmatic, as Atish also has highlighted. People still die. Still, with the septic shock, mortality rate is 40%. So we must also be open to the out-of-the-box approach, and let's not just only believe in the guidelines, because guidelines are very funny at times. Don't give fluids, then give fluids, and now again don't give fluids. So I'm really confused. So please use the physiological sense at the same time, which I believe.
One more small thing. Most of the patients are comorbid and have using ACE inhibitor, ARBs. What about this specific situation? Patients who are receiving angiotensin II. Is this study saying so? Or any other thing, say that's renin level, say. Renin level, if it is any impact on that angiotensin use in septic shock patient, that may be a good idea. So I think
very good question. Very good question. Just to highlight one thing, because you raised something very important concept. If you go back to the coexisting physiology, the textbook which you follow in anesthesiology, they said there are three main physiological excesses which are responsible for maintaining a soft blood pressure. One is your sympathetic parasympathetic, right? The second is your renin, angiotensin, aldosterone. And third is vasopressin. So physiologically, it makes a common sense that you should use all the three excesses, especially if your patient is becoming vasoplegic. So I think, especially in the cases where you have been having angiotensin II receptor blockers, you should use the other two more often, like your renin, So I think now we can close it in the interest of the time.
Sir.
Thank you.
Yes, sir. So thank you, Team Siliguri and Team Agra, for the wonderful insight and discussion. and thank to dear experts and guides and all who have joined us and watching this video for your blessings and encouragement and loving warmth towards ISCCM Journal Club and making this resounding success. That's all. Long live ISCCM. Jai Hind.
Thank you.
Thank you.
Thank you.
Thank you.
Good
Bye.
night.
Thank you and have a good
Thank you.
night.
Good night.
Yes.
Good night.
Very good
Good
night.
night.
Bye.
Bye. Thanks.